patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome to this special October is for Livers episode of GLI Live, our thought leader series of interviews. Backed by popular demand, we have Ysabel Duron, the head of the Latino Cancer Institute. We could not do a Cancer Month series without featuring you and continuing our conversation. Welcome, Ysabel.
Thank you very much. It's really lovely to be back here with you again, where we can have a much more intimate conversation.
Yes, I'm so excited. For those of you who are new to GLI Live, please go back and find our series of roundtables featuring many, sort of an all-star cast from the Hispanic cancer community. The leader of them all, a member of the Biden administration's Cancer Moonshot team and National Cancer Advisory Board member, and so many things that we would take the entire 30 minutes if I listed all of your titles and accomplishments. So let's really just dive in to the conversation on what is the President's National Cancer Advisory Board?
Well, first of all, I want to say, Donna, thank you for inviting me. Second of all, I think you know very well, as we saw that lovely opening about you at all these tables, is that as advocates and as members of our community, where we see a lot of disparities and lack of address on these very issues that are so critical to us, we tend to have to go sit at all of these tables and and say things.
Yes.
The thing about the government is it can be very complex, as we all know, and there are some separations of duties here, and I'll see if I can unravel them for you.
Thank you.
I was because I was pummeling the White House and the White House advisors and the National Cancer Institute and the Javier Becerra, the HHS secretary, and then my own congresswoman about they need community voices at the table when they announced the reignition of the Moonshot. I suddenly was called on to
that sometimes
right?
happens.
What happens when you stick your nose in it, right? So then you have to step up and serve. So what actually is the National Cancer Advisory Board, that actually is the advisors to the director of the National Cancer Institute.
Okay.
The NCI, which gets an over $5 billion budget from Congress, is aligned and linked, of course, with the president's cancer panel, which advises him and which he listens to. And it's aligned with the National Scientific Board of Advisors. And I mean, we got.
I live in Washington, D.C., so I do know. But this is why these conversations are so important, because in most of the country, all of this is very opaque, very obscure to people. And as advocates who want to create change, knowing where to go to make the changes is often the hardest thing to figure out. And so, yes, all of these various entities which have different responsibilities for cancer all do play a role. And so,
and can I say, Donna, to that
please.
point, because when you asked me in the first place, even I had to learn about the differences, and even I had to learn, or even currently, learning the rules of the road. Because believe it or not, folk out there, they do have ethics. They do have lines of demarcation about what what is not ethical,
Mhm.
acceptable, where conflicts of interest exist. And so part of me as an advocate who wants to push through every door, demand an audience, and put my argument on the table suddenly has a different shift now that I am inside at this table. Now, the NCAB, the National Cancer
Mhm.
Advisory Board,
Mhm.
is publicly, when we have a meeting, it's open to the public. So you can go online and watch what's going on. And that's the transparency that is needed within government. But I mean, it's still those inner workings, which you well know, uh, is trying to figure out all the different departments,
Mhm.
all of the different funding streams, all of the different players, and then trying to learn, who can I go to when I need this? Oh,
Right.
I go there. I have to go here. I mean, it is, I'm still in the onboarding process, believe it or not.
Mhm.
I was informed a year ago in August that I was being
Mhm.
considered, but I was told I couldn't tell anybody, or in my interpretation, they would
Mhm.
let Guido to get you. So I think I told one person in deep secrecy. Now, don't say anything. And it took till like the following February for me to get a note from them that you're going to be appointed. And then the official appointment came 2 days later in a press release. But
Yes.
then there's this whole onboarding process for the
Mhm.
federal government that, and they've got thousands of employees. So you can't expect that you're going to be turned around in 2 days. But it was really interesting because they do look at who are you out there working with?
Mhm.
Where is your funding coming from? Who might you be obligated to that is in conflict with your sitting at our
Right.
table? So they are really, and you have to take an ethics test
Mhm.
and all of that. And I'm telling you this because I want the public to know that, in fact, you know, the government does put in guidelines. It does try to be transparent. It does try to be ethical. It does try to make sure that we're not abusing whatever power we have. I quite frankly, Donna, just don't know how much power I have. You know,
I think you have a lot, but to the point of the ethics process, and we help many patients navigate that as they want to um, take their advocacy to the next level
mhm.
within FDA or in other committees. It is very important to understand and to document and to follow all of these rules. My husband still, grumbles from time to time, because I, asked him, and he was very gracious enough to sell all of his individual stock. We
Oh,
don't own individual stock, not just me, but my spouse as well, because you report on your spouse. And so for
yeah.
me to be able to sit in many of the government roles that I'm able to sit in, we have to have divested of all of those interests, and I have to be very cognizant of things that I sign up to do, and there are lots of things that I say no to, just to be able to preserve that ability to have that voice within certain government entities.
And I think that's one crucial thing to understand and know. That's all of the bureaucracy in
Right.
the process. The second thing to know is that if you agree to join, you better not be afraid to use your voice.
Absolutely.
You know,
We're
and
not
and
just warming seats here.
exactly. I mean, the whole point, and I did ask that question, how much power do I have? I mean, in other words,
Hmm.
when do I start crossing lines? Or can I call the director and say, and someone said to me, well, you have actually quite a bit of vested power in that. You're
Hmm.
representing the populace. You're
Yes.
coming from outside. Most of the folk on the board, there are
Hmm.
several industry people, but the rest
Hmm.
are all clinicians, or they're at major cancer centers, or they're academic researchers, et cetera, et cetera. So being, as you indicated, one of the first patient advocates on the NCAP
Yes.
is a big shift. And so people were giving me advice about, don't always fight everything. I said, but I care about everything, right?
Hmm.
And then they said, so choose your battles, which we've all heard before, right?
Hmm.
But the second thing was to find those allies and make sure that yours isn't the lonely voice in the room. But sometimes you have to accept you're the lonely voice in the room. You have to raise the issue
Hmm.
from the grassroots to make the folk at the grass tops recognize you guys don't recognize this. You don't see
Hmm.
this. You don't realize this. Ignore the phone. And and that's why we have to be unafraid, because we are sometimes saying things that seem like left field,
Hmm.
aren't couched in deep scientific, you know, knowledge and verbiage.
Right.
And we have to be not afraid to say, I may look stupid or feel stupid, but I'm going to say it anyway,
Hmm.
and see if I can't bring some allies to my table or get some head nods
Hmm.
that someone said, oh, yeah, I get that. Or finally, someone is saying it from the community
Right.
and not from my perspective.
Because there often are those champions. They may be thinking that or feeling that, but you can actually empower them to come forward, um, with your community experience, with your lived experience at the forefront.
Exactly.
Um,
Exactly.
I and one of the you tap into something that so many advocates ask. How do you prepare for meetings like this? There's certainly the lifetime of experience, and there's specific reading for the agenda, but do you go back and survey your community about certain issues before, so that you can come to the table with some perspectives that speak to a particular point? Or how do you prepare for these types of meetings, representing not only yourself but so many others?
Well, I've been now in the cancer space for 23 years.
Yeah.
And the first 14 of them, no, 14, 15, 16, 17 of them, I was literally on the ground in
Hmm.
community and built two local community agencies. One was with breast cancer patients,
Hmm.
and the other was all patients, because I wanted to make sure we served men,
Hmm.
who oftentimes, as I tell them, their biggest risk factor is being male, because, getting them to pay attention is
Hmm.
much more difficult.
Yeah.
And oftentimes we saw they came in with a later diagnosis and a higher mortality rate
Hmm.
as a result. So, address the community. So what they did was they became my community of practice, if you will. I
Right.
learned listening, watching,
Hmm.
finding out from them what are the gaps in services. And we were serving low income Spanish speaking immigrant,
Hmm.
um, uh, and just the community of the most vulnerable population, those, who had no insurance, little insurance, Medicaid, you know, just a lot of challenges in their life just to access healthcare, just to
Hmm.
make it, something part of their daily lives, which it possibly wasn't. And that's why they're not screened early enough. They're not going to screenings. But anyway, they became my community of practice and learning. It was like me, a doc on the, doc in the field, learning,
Right.
watching, and experiencing. I mean, my own cancer experience in many ways was so different. It was
Hmm.
exactly why I needed to say I said, where are all the Latinos in the private offices where I went to get chemo?
Hmm.
I wasn't being slapped with bills I couldn't afford. My insurance, because I was working as a journalist and had very good insurance, it
Hmm.
took care of most of that. I quite frankly don't even know what the final bill was, because I was only paying these little amounts.
Right.
And now we're finding out that 62% of people with a cancer diagnosis have debt.
Yes.
3% go into bankruptcy. Another 48% are, are constant bad debt. And some when we've done some surveys, have lost their homes.
Yes.
They can't afford the rent. It's, should I buy the medication or should I get food for the
Hmm.
family, right? Uh,
Right.
and then we saw, you go into the doc for your next visit, you haven't
Hmm.
taken all your medication because you're not quite sure what you're supposed to do with all of that. It's all in English and you don't know quite what. And then you show up and the doc says, how are you feeling week? Well, I'm not feeling so good. Well, didn't you take your medicine? Well, and then they think the patient's out of compliance. No, the
Right.
system is out of compliance because the woman wasn't even properly told how to take her meds, which, when. And what we did with our learning and navigation,
Mm-hmm.
we wrote it in Spanish, color coded the medications, gave
Mm-hmm.
them what to do and when to do it. And that shifted and changed the knowledge, the awareness, and the participation in their own healthcare. And so all of this stuff to me is learning. That's preparation. And then,
Yeah.
of course, I got engaged in collaboration with research because I know there was stuff there I needed to learn.
Mm-hmm.
And I also said, so where are all the Latinos when I went to the cancer conferences?
Mm-hmm.
When they were shoved in a corner with maybe a little 3 or 4 demonstration models
Mm-hmm.
and stuff. But with that pool of researchers also grew. But these all became my learning tools, and helped me develop this more 360-degree knowledge. And so I then chose to sit at those tables to learn more and to bring what I was learning, but to learn more. So my mantra kind of was bringing science to community and community to science.
I think that that is brilliant, of course. And it's a great service to the scientists, to the researchers, to those who don't know that all of those problems are happening and those barriers are in the way when they think they're telling a patient, go get this prescription or go get this treatment, and they think that all these things magically align and happen. It does them a disservice to let them to continue having those delusions.
Exactly. You're absolutely right.
We brought our whole team, the whole organization from Europe and everywhere to the University of Miami
Mm.
a few weeks ago to talk to the doctors, to talk to whomever we can talk to, and really see and understand how services were put together, noting, oh my gosh, if you have a cancer visit over here, but you're also seeing that, how do they get from there to there? And those very, very practical things that you and I know, but I need my entire organization to know so that they can carry that forward. It was really vitally important, and a question I ask at every team meeting every week until they started recognizing that I was going to keep asking it was, have you spoken to a patient this week? And at first only a few raised their hand. Now everybody knows they need to go find a patient to talk to that week. And have you spoken to a physician that week?
Yeah.
Because if you haven't, then we can't really create education. We can't solve problems if we don't really have people telling us what their problems are.
So back to your initial question about how
Yes.
do I prepare, based on that one bit of that learning in those
Mm-hmm.
early years really prepped me. Unfortunately, the one thing about having what I consider a national organization that looks outward instead
Mm-hmm.
of into community
Mm-hmm.
is me reorienting where I need to be in
Mm-hmm.
order to move forward on addressing these disparities. And for the longest time, I was looking at addressing how do we serve community on the ground. But
Mm-hmm.
the more I spent time addressing the disparities along the cancer continuum,
Mm-hmm.
the more I recognized I can bring in here one patient at a time. But it's the system that has to
Right.
change, or will never change the disparities. And so that's when I realized that I had to go to the dark side. Excuse me all. I had to go to learn how to advocate, in city hall, but in this case at state or at the federal levels.
Mm-hmm.
I had to get engaged in making the sausage, you know, and this is the thing I really, quite frankly, don't like, but I recognize it as something now at this level that I need to do. Amplify the Latino concerns, work and collaborate with other community-based organizations, continue to engage in research to move that forward as well so that it's serving community, and then finally sit at the policy making tables or in coalition with other
Right.
groups to move things forward. And so I don't have the same day-to-day kind of
Mhm.
experience with a patient that we used to have, or that I used to have with my promotoras, with the navigators who were
Mhm.
in constant, who would say, so and so's father called me up on midnight
Mhm.
from Mexico, this kind of stuff. And they
Mhm.
were there to answer. They
Right.
were there to go to 25 funerals. They were there to take the call to come to dinner at the family's
Mhm.
house, because now they're part of the family.
Right.
They were there to go to the house and encourage someone to show up at the hospital because they needed to go into emergency when they didn't want to go. And so those were my lessons. Those were my learning
Right.
curves, so that I could sit at these tables and say,
Mhm.
whoa, just a minute, folks. The end all and be all is not in research. There are there are programs on the ground delivered
Mhm.
by community-based organizations that really need to be done. Raising awareness, dispelling myth and misinformation, creating pathways through mistrust to trustworthiness,
Right.
and help engage, as I said, bring community to science and science to community. The other day I came up with something. I mean, it was said by somebody else whose name, all I can remember is his first name is Teo. He's well known. With so much in this brain, I forget half the
Mhm.
things. I have to go way back into the filing
Mhm.
cabinet to pull out that memory chip. But anyway, what he said was, to me, was most important. He says, health begins in community.
Right.
And what we're finding is all of these systems are revolving around community, as opposed to uh, building relationships, peer
Mhm.
relationships, so that there's bridging with community, and helping activate community so that it recognizes and accepts that it has responsibility in its own good health, and that it can do certain of these things, while the systems themselves are trying to remove some of those other barriers that make it more difficult to challenge them. But even when you go back to liver cancer, we know there are things an individual can do to diminish their risk. It's not something the system can do for you. It is something you have to do for yourself. But we need to
Right.
engage them. We need to educate them. We
Right.
need to activate them.
Because we see many of the same disparities that you saw in your Latino communities and African American communities, particularly with African American men showing up diagnosed with liver cancer in far more advanced form. And so we know that we can't meet those goals of the cancer moonshot, and of these lofty programs without solving for liver cancer, without putting all the things in place in communities and in clinical settings for liver cancer in much the same way they are for breast cancer or other cancers.
Right.
But
Well,
they've been largely ignored.
I don't have to tell you, Miss Choir. I mean, it is probably one of the most most cancers in the globe. It's not, and it's increasing, and we're seeing it more in the Latino community. Like in 2019, almost 5,600 Latinos were diagnosed with liver cancer. Over half of them died. Over
Right.
half died. And we're seeing an increase. And we know that it's genetics, it's environment, it's lifestyle. You can address those, even with the genetics, except for they don't have a genetic test. But we know that genetically there's a predisposition for 48% of Latino. There's a genetic predisposition to fatty liver, right? So those can be addressed even in the first three levels of that
Right.
spectrum, with first awareness, then education, then testing, then putting them on the right nutritional path. All these are steps that can be accomplished. You have to invest in it. So that's one of the things I said to those people I was talking to at the Fed level. You need
I'm
community
so
voices
glad.
at the table.
Thank you for that. Thank you for representing liver cancer, because it is not otherwise mentioned. When I read releases and statements and things like that, I didn't see the word liver. You know, my eyesight is not what it was a few years ago, but I didn't see the word liver. And yet it is one of the most preventable, because as you were mentioning, some of it is driven by hepatitis C, where we have cures, or fatty liver disease, for which if we address obesity and type 2 diabetes, we can pull back. So hepatitis B as well has a vaccine. And so there's so many things that we have already invented, have already researched,
Right.
already know can help reduce and prevent liver cancer. And if we put so many of those in place, we would have a much easier job with the few remaining cases of liver cancer that we would have, particularly with all the new medications we have. But if we don't talk about it, if it's not on the agenda, then we'll never get there.
But to me, that's part of my prescription. That's where I would invest, because this can apply to multiple cancers in our communities.
Yes.
That first stage, and then you move them into those screenings and into those tests and in for that regular checkup if there is already diagnosed or a predisposition for liver, just to keep testing, right? And as I've said also, that, you know, there is no macro solution. There are only micro approaches, community by community by community. But getting them to invest in prevention and at the community level, not through public health systems, not through research collaborations, not through cancer centers, but provide funding mechanisms for community-based organizations who know how to work in community to show, to step up, to scale out, and to do what they can do and show and demonstrate evidence-based. These are working. Oh, maybe we can tweak it. Send us a researcher, they'll show us, we'll test it, you know, then we'll make it evidence-based, and we are all showing we're working together. I said, I say a little tongue in cheek, but I said, you know, implementation scientists come to the community with logic models. The community uses logic and goes to work.
Yes. I think, as you said, but bridging those two, I've encouraged so many community activists who have developed a really effective program. I'm like, please write it up. Please let us help you submit it to some journal so that people believe in it. I know it's true. I don't need that to validate it for me, but to make sure that it's included in the literature that later becomes guidelines and guidances
and gospel,
and all exactly, and that it gets into the process. I need you to write it so that we can publish it, so that it can become part of the evidence base.
You know, one of the things that I advocated for that's going, it's part of a 7-page editorial that's going to be released next month, but it was about the high cost of these journals, and community can't afford them. We can't learn because we can't access. You go to these journals, they might give you a little abstract, maybe, if you're, they make you sign up for all of this stuff, right? And then you have to worry about the citations, and you have to make sure and all of this. Not that I wouldn't do that, but the point is that I said, if you want the community to come along for this ride, you've got to stop siloing your knowledge, and you have to share it. And I said, and I'm not here to to help lower the prices for all of those researchers who have to, you know, justify your publication, but you need to give the community a discount or a break, or give it to them free. You need to. But they're also in the publishing business and the profit-making business, so getting them to move. But that's now it's going into an editorial that's going to be published.
And I will make sure that at least one member of the National Library of Medicine Friends sees that. I will go down across the hall and put it on his desk.
It's not.
He knows how I feel about that.
Right. I think it releases in September. I'll try to make sure that you get the official link to it.
Thank you.
Or maybe the whole copy. What am I talking about?
I'll make sure I get the whole copy. And that is that is so important, to be accused, as I'm sure you have been, of patients don't believe in the evidence or patients don't follow the evidence. Well, we would if we could read it. We could if we were in it. We would if there were so many things that happened that made the evidence much more relevant to our experiences and to the decisions that we need to make on a daily basis. And
You know,
so,
if they tried that with me, they'd certainly hear back. But the bottom line is, well, the bottom line is, Donna, I am a journalist by training.
yes.
So I like facts. I like
Mhm.
data, right? And I've often
Right.
told researchers I've really enjoyed the opportunity to work with you, because I wished I would have had a researcher in my pocket when I was a journalist. I would have been a so much better journalist, because I've really, how to dig and dive, and even more so.
Yes.
When you're a journalist, you're on the run. Of course, we didn't have, in my early days, we didn't have Google, to help us do things quick, or to find PubMed or any of that stuff.
Mhm.
But really, I've really enjoyed, and I've loved having a lot of Latina cohorts, research buddies, and so on, to help me understand the ins and outs of not only the issues, but the politics of it, right? And where the gaps are for Latino communities, and so on and so forth. So, but I like to tell them, no, I like data, and I like facts, and I like evidence, and I'll do it my own way. Sometimes I think you're making it so hard. It takes you
Mhm.
8 months to set it up. It'll take me 8 hours to go into the community and do the same damn thing.
Exactly.
You know,
Exactly.
ask questions, right? But no, we have to get it approved, and so on and so forth. But that's the difference, because the community trusts you. So they'll let you stand there most of the time,
Right.
and they'll let you ask the questions, as opposed to folks coming in and they're complete strangers, and they don't know why they want this information. They don't know what they're going to do with it. And why should I help you? What's going to do, how's it going to help me? So
Exactly.
I am, all of that I bring with me to see, how do I now influence change, and what does change look like? Is it little
Mhm.
things, or is it big stuff? I like big stuff, but maybe it's those tiny little steps,
Mhm.
you know. Well, first of all, where they might have 2 or 3 more patient advocates at the table, right?
Yes, being the only one is a lonely place. I know early in the patient engagement movement, I got in a lot of places because they were like, Donna, you can stand to be in the room without without losing every. I'm like, yes.
Mhm.
I don't know if that's necessarily true these days, but
Well, I think, you know what? I think it's a muscle. I think
it
you
is.
do have to develop it. I mean, possibly working in journalism, out in the street every day, meeting communities, asking
Hmm.
questions, and then doing, I anchored a
Right.
weekend news show. So I got used to both being in the front of the camera and out in the street.
Right.
And so I feel in my mind that I really have an understanding of different communities,
Hmm.
because, and what my always goal was not to go in necessarily and just look at the problem, but see what solutions they're coming up with.
Right.
What are you doing to correct this, in collaboration with City Hall or with whomever?
Hmm.
So, because I think the community needs to know it can do, is
I
doing,
think that's
right?
the most exciting thing, to recognize that communities have assets, they have strengths,
Yeah,
and to bring those forward, into these rooms, and help them operate from a place of recognizing the community strengths and what people do have to offer, and
right.
how capable people are if they are lifted up or well resourced or given information in language and in culture, and trusted in the way that the medical community asks to be trusted.
Right, right. And so uh, I just hope, because sometimes I feel I'm the loud voice in the room. I don't know if I'm getting it done, but I'm sometimes when you might hear your own voice in your ears,
Mhm.
and you're going, oh, calm down, calm down. Be quiet, be quiet. But I think I came out of the womb like that, so it's in the DNA, you know? I can't help
We
it.
are grateful to have you, all of us, no matter what the cancer that we may represent. We are glad to have you in the rooms where it's happening
Good.
for us until some more of us can join you. And
There
the
you go.
reinforcements are coming, I'm sure.
I hope so.
Yes. Thank you
Please be
so
sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.